Thank you, sir. Thank you for the kind words. And we start immediately because it's the last lecture and I'm sure everybody's tired. Yeah. So this is just an overview of ultrasound in the eye. The next 15 minutes we're just going to scan through the different appearances on ultrasound and how clinically they are relevant. So we all started with doing 10 megahertz ultrasound, then matured to do 20 megahertz ultrasound, required only in few amount of cases, and then the 50 megahertz probe showed us the UBM. So what all have we learned from all this? We always look at the vitreous cavity first, and that probably is where 99% of ultrasounds is required and is mandatory for a clinical diagnosis. But usually when we see the vitreous cavity, you as an ophthalmologist probably have the clinical picture in front of you. But we as somebody doing else has to know what is the problem with the patient. Without a clinical picture, frankly, to make a diagnosis only on ultrasound for what the pathology is extremely, extremely difficult. These are 4 different pathologies that I have brought to over here. Look at it only on the appearance of it, it's very difficult to say. Ultrasound does not tell us whether these echoes are floaters, these are hemorrhages, or this is inflammation. There is a clinical picture which supports the diagnosis of ultrasound. But it's more important to know on ultrasound is what are the effects of those pathologies on different structures of the eye. Now, if you look at few discrete, freely mobile echoes within the vitreous cavity with no thickening of the chorioretinal layer, it is definitely we are dealing with floaters. On A scan, the reflectivity is less. As opposed to that, a non-very pathological condition or not very drastic, but looking very drastic on ultrasound is asteroid hyalosis, where there are echoes the same like this, but they are extremely bright. And on high A scan there's high reflectivity. But if you look at the area in front of the vitreous cavity, you always see a circumferential clear vitreous. So this is the hallmark of asteroid hyalosis. That's because all the fat comes right into the center of the vitreous cavity. So these two are conditions which really of no great pathology for the patient. But if you look, report this as hemorrhage, which is normally done when you see echoes like asteroid hyalosis, then it becomes a problem. Now this is vitreous hemorrhage, and I can see the arrow, yeah. And this is vitritis. Can this echoes itself tell us whether it is hemorrhage or vitritis? Not possible. We need to have a clinical picture. But if you look at the ocular wall, then it gives us some amount of clue. This is vitreous hemorrhage right into the center, and usually the ocular wall is absolutely okay, normal, unless we are dealing with somebody who has a macular degeneration or some very severe diabetic retinopathy or traction. Whereas in hemorrhage, vitritis, there is always some amount of thickening of the chorioretinal layer or the ocular wall. Why? Because the echoes are more at the posterior pole and they cause inflammation of the chorioretinal layer. So the next question that usually if there are PGs over here are asked in the question is, what is normal chorioretinal thickness? And when do you call it abnormal and when do you call it thickened? Does anybody know the answer? You will not know the answer because there is no answer. Chorioretinal thick, look at this normal person. Can you differentiate between the retina, choroid and sclera over here? Not possible. The ultrasound does not have the resolution to differentiate between a normal retina, choroid and sclera. So when you start seeing them separately, means it is thickened. So do not mention, I've seen a lot of reports where people mention 2.1 millimeter, 2.3 millimeters thickness. That doesn't have very much meaning. Mainly if it is thickened means your vitritis has now become endophthalmitis and you treat the patient as endophthalmitis. So this is the role of ultrasound in vitreous inflammation. One, density of echoes to tell you whether it is only vitritis or how much is the extent of vitritis. Second, to know whether there is chorioretinal thickening. So vitritis has now gone into endophthalmitis. Stage 3, there is fluid in the Tenon space. So endophthalmitis has now become panophthalmitis. So grading is possible on ultrasound. And 4, what is the status of the retina and the choroid? Can you see a bullous membrane over here? This has caused a choroidal detachment. So all these findings are very important to be mentioned in an ultrasound report, and it goes a long way into the treatment management of the patient. Which type of inflammation is there in the eye? It's not possible on ultrasound. It's actually a microbiological diagnosis. But this is only posterior scleritis is one where we can really ultrasound makes a diagnosis when clinically it is not possible to know what is going on. This is an extensive case of posterior scleritis, but sometimes very subtle pain in the eye, back part of the eye. Clinically everything is normal. Ultrasound is the only way to diagnose posterior scleritis. What happens? There is thickening of the chorioretinal layer at the posterior pole, and as you go anteriorly, this thickening reduces. And there is fluid in the Tenon space which tracks along the optic nerve and causes the T sign or the inverted T sign. If you are in, you're not in Bombay, but if you are in Bombay, this image always goes as an exam spot to everybody when the exam is held in Bombay. So it should be the similar over here. Fine. Now we come to inflammation, hemorrhage as another common diagnosis that we look at. So what are the points? In inflammation, we said about the density, chorioretinal thickening, fluid in the Tenon space. Whenever we deal with hemorrhage, there are few points to be mentioned. One is the density of the echoes as usual. How much is the hemorrhage, which will decide probably to wait or not to wait for surgery. And second is the effect of all this on the retina. Look at this, the hemorrhage gets absorbed with formation of membranes. You can see the membrane formation over here. This is the optic nerve. This is temporal to the optic nerve. This membrane is attached to the macula and causing macular traction. So here is an indication for vitrectomy. So ultrasound helps us to decide on the treatment modality if we look at all the possible findings on an image. So again, I brought the image over here. This is hemorrhage and this is vitritis. Can ultrasound tell which is which? Not possible. We require a clinical picture in that. Fine. From echoes, we turn to membranes within the vitreous cavity. So membranes within the vitreous cavity are basically three types. One is vitreous detachment, vitreous membranes, or a retinal detachment. Okay. When the vitreous is not attached to the optic disc, it's fine. We do not have a problem in differentiating that. But when the vitreous gets attached to the optic disc, when it comes as a differential diagnosis of retinal detachment. So there are lots of points which are mentioned in the history, literature of differentiating an RD from a PVD. But one is the most important criteria. If you remember, we are probably true 99% of time is the texture of the membrane. Remember that a retinal detachment is a thick, uniform membrane. Look at this texture. It is a thick, uniform membrane. Always an RD is a thick, uniform membrane. Here are three examples of PVD attached to the disc. Look at it. It's a thin, sorry. It's a thin, undulating membrane. A thin, undulating membrane. And a thin undulating membrane. There is always a smooth attachment to the optic disc for an RD. There is always an irregular attachment of the PVD to the optic disc. And there is always elevation of the optic disc when a PVD is attached. It is never in when an RD is attached. So these are the points to remember when you differentiate an RD from a PVD. So just in summary, retinal detachment is a thick uniform membrane, PVD is a thin undulating membrane. It has good after movements, PVD does not, RD does not have after movement. And if A scan, if you want to look to, there is a high reflectivity in RD, not on a PVD. You will face certain issues when you are looking at post-operative RDs doing an ultrasound. There are certain points to be remembered in mind. One is this, it is called as the vitreous cut. It is the uncut vitreous which is left out when we do a vitrectomy, and it is always seen as a circular or an irregular taut membrane in the anterior part of the vitreous cavity. This should not be confused with an RD. This is an RD where there is an optic disc and this is a scleral buccal. You can see that there's a presence of an RD. There is vitreous hemorrhage post-vitrectomy. You can see the scleral buccal also, no RD. But look at a membrane here. This is what I've seen multiple times. You must have also seen that in post-vitrectomy patients, when we suspect an RD, you always see a very small elevated membrane somewhere at the posterior pole, and we say that this is an RD. If you follow up these patients, that membrane disappears over a period of time. These are just small areas of subretinal fluids which do develop. How do we differentiate that from an RD? Look at this membrane over here and look at this RD over here. Again, the same issue. See, it's a thick uniform membrane. This is a very thin undulating membrane. So it's not an RD and it should not be confused and should not be reoperated. Coming to leukocoria, I'm just showing you two conditions. There are 3-4 slides here where two conditions, clinical conditions having a similar picture on ultrasound, but few findings can differentiate these two conditions. These two patients were of leukocoria, came to me for leukocoria. Look at this membrane. Both have a membrane at the posterior from the optic disc going anteriorly. This is PHPV and this is RD. How do we differentiate that? This membrane is thicker at the posterior pole and thinner as it goes anteriorly. Because the posterior hyaloid is attached to the posterior capsule, it has a very thin attachment over here. This is a chronic closed funnel RD. It is always thinner at the posterior pole. As it goes anteriorly, it has to go to the ora serrata. Anatomically, the RD goes to the ora serrata, and therefore it is thick anterior. So two conditions which are two different pathologies having a similar picture on ultrasound. Again, same problem over here. Patient has absolutely PL or no PL sometimes, comes to us to know whether there's some visual prognosis left or not left. Look at these two ultrasound pictures. They look almost similar. But if you look closely over here, in this picture, you are seeing a sort of a Y-shaped black membrane coming out here. And here it is total opacification of the vitreous. This is total organized vitreous hemorrhage, and this is a closed funnel RD. Now, why will you say that this is a closed funnel RD? I told you that RDs are white, bright. This is black. Why is this black? Because this is a chronic retinal detachment. In presence of chronic retinal detachment, the subretinal space gets a lot of depositions of cholesterol, calcium, whatever, and they become brighter. In presence of that, the RD appears black. So that's the reason why it is. So two different prognosis, two different conditions. Look at these two pictures over here. This is also a similar condition. These are post-operative cases. This is a drastic condition which occurs as a post-operative cataract complication. Both of them had very high pressures on ultrasound during table, and they were sutured and was given off and sent for ultrasound. Look at these two pictures very, very carefully. They appear very similar. Here it is complete opacification of the vitreous, and here in front of the optic disc you can see some sort of a triangular area. Clear? This is post-operative vitreous hemorrhage. This is complete suprachoroidal hemorrhage. Why? Because the choroid cannot get attached to the optic disc. It has to stop short of the optic disc. So this is suprachoroidal expulsive hemorrhage. This is vitreous hemorrhage. Again, a similar type of a picture. Now coming to mass lesions in the vitreous cavity, we always discussed retinoblastoma. One thing that I want to point out here is in a retinoblastoma, we always say that there's presence of calcification. But calcification occurs only in 50% of retinoblastomas. So 50 do not calcify. So what do we need to remember? One we need to remember is that we always should measure the axial length of the eye in a child, compensating for the age of the child. If in retinoblastoma, the axial length is normal or increased. And all the other conditions which mimic a retinoblastoma or are of leukocoria, axial length is reduced. Okay, so that's a very important point. Second point is calcification. Third is always look at the A scan. It has high irregular reflectivity on A scan. Two, you should play around with the gain settings in the machine. So the retinoblastoma calcifications are micro calcifications. They may not be apparent on a routine gain setting. So look at this mass with calcification here. And here I have changed the gain settings. The calcification becomes more prominent. So these all things we can play around with the machines there. So these are three different conditions which mimic a retinoblastoma. Again, I told you it is the axial length very important. This is ROP, which is closed funnel detachment with a lot of retinal proliferation here. This is Coats disease. There is a total retinal detachment and dense subretinal echoes because of cholesterol. And this is PHPV, the case we had already seen before. So these are the differential diagnosis leukocoria. Coming to choroidal melanoma, it's the only tumor in the in the human body which has uniform echo texture. No tumor has a uniform echo texture. Why? Because the cut section of a melanoma, these melanin cells are uniformly distributed. Therefore, there are minimum interfaces, and therefore you get a uniform echo texture, and that's why you get this classical cascading reflectivity. When the A scan passes through the mass, there is a cascading reflectivity noted. Okay, so this is the low A scan of that. Coming to another tumor, how do we differentiate that from a melanoma? Choroidal hemangioma is one tumor which mimics a melanoma. But always on the surface of the tumor, you will see a bright echo, which is a phlebolith. It may not be appreciated at normal gain settings, but again, if you reduce the gain settings, you can see all the echoes are reduced and the phlebolith is noted very well. So that's the way of utilizing the machine in front of you. The same thing can be done for cases when there is localized suprachoroidal hemorrhage. Look at this presence of a choroidal mass over here. We may sometimes think that this is some sort of a granuloma or anything like that. But if you reduce the gains here, you can see that the choroidal membrane is seen very clearly on this picture, but not seen on this, because the echoes are hemorrhagic echoes mask the membrane. So always utilize the machine which is in front of you to change the gain settings before you say that everything is okay. This is what I want to show you a very interesting case. Army gentleman around 80-85 years old. He had a loss of vision for 2 or 3 years. He presented to a patient unilateral, and somebody suspected a mass lesion in him. Look at this picture when he came to me here. I also thought that this is a dome-shaped big choroidal mass lesion, and I said that you don't have any, this doesn't look like a melanoma to me, but at this age, metastasis is the most possible diagnosis. So we labeled this as a metastasis and said that you should get scanned and PET scan, everything. But this gentleman said, bye-bye, I'm not interested in doing anything. I have lived my life. Whatever happens to me, I'll go home and see what is going on. So he went home, 6-8 months, he did not come back, and one fine day he landed at my clinic, saying that let's do a scan again. He didn't go to anybody, straight away landed out to my clinic. This is the scan 6 months later. Look at this. Now what we saw for mass here has started seeing as a dome-shaped lesion over here in the periphery, and there's some echoes right into the center. This was spontaneous suprachoroidal hemorrhage with vitreous hemorrhage earlier, which over a period of time had got absorbed, and he is now seeing the choroidal hemorrhage very clearly. So he said, अब मैं अभी तक मैं जिंदा हूँ, शायद जिंदा रहूँ ना रहूँ, पर मैं फिर घर जाता हूँ, आपके पास 1 साल के बाद आऊँगा. And this is the picture after 1 year. You see here that choroidal hemorrhage has almost absorbed. There is just thickening of the choroid here, but he has developed vitreous hemorrhage with a PVD attached to the disc. But this diagnosis of choroidal metastasis was wrong, though it looks like a metastasis. If you show 10 ophthalmologists, they will say that this is a metastatic lesion. So sometimes even follow-up treats a lot of things. Follow-up also helps us in another condition, and that is in trauma. You might probably not see masses every day, but trauma is something which you see every day. And this is what I have learned the very, very hard way. What happens in Bombay is somebody gets a trauma, and ultrasound is done by me on the 2nd or the 3rd day. And whatever I report, then the patient goes away. After 15-20 days, he lands up at somebody, some vitreoretinal surgeon's place, and reads my report that there's a presence of an RD. And he is taken up on the table for a report which is done 10 days back. And on table there is no RD. So this is what trauma does. Okay, yeah. Okay, so look at these 2 pictures over here. These are pictures of trauma which are on day 1. Look at this picture. I'll control them. This thing here. Up mouse mat hilao. Idhar, So this is vitreous. I reported this as vitreous hemorrhage with few membrane formation and no RD. This patient fortunately came to me after about 2 weeks prior to his surgery, and look here, the hemorrhage has got absorbed and there is development of an RD. Another patient over here, this was reported by me as vitreous hemorrhage, and there was a presence of an RD, which I said, and the presence of a subretinal hemorrhage. So I alerted them that something needs to be done. And this patient after 2 weeks came to me for a follow-up. All that thing has got absorbed and there is a vitreous hemorrhage with PVD attached to the disc, no RD. So a case of trauma can fool us all. So, and over a period of time, every day that situation keeps on changing. So whenever we plan to do a surgery, one should do an ultrasound prior to that to know what is the condition date prior and not make a decision for an ultrasound which is done earlier. Again, intraocular foreign bodies, I don't want to go in details. We know very well that there is a bright echo with shadowing. This is what happens with glass foreign body. Though the foreign body is small, it looks very big because of the reverberation artifacts which are there. Again, look at this picture over here. It was a case of trauma with suspected foreign body. You can look that there is hemorrhage over here, some suspected foreign body in front, but I'm not sure because there is no shadowing. This is the optic now. So again, had to play around with the gains, and I reduced the gains. All the echoes have been reduced, and you can see the foreign body very well. Same thing happens in the orbit. If you want to look at the orbital foreign body, the orbital fat and the foreign body are of same intensity. You need to really reduce the gains to see the very well. So play around with the machine a little bit. You might be able to get a little bit more answer. Thank you very much. Metastasis, hemorrhage, only melanoma has low spike. Hemangioma, it will be more. But in hemorrhage also, yes. Yeah. Even in hemorrhage, it does the same thing. Same. That's why the confusion was there. Almost 80 to 85% have phlebal. Thank you, sir.
So, thank you very much. Now, I'll not hold you because now inauguration is going to be there. So, it's a message continuously coming at 5:30. But I don't know, the session was up to little later than that. But, so I'm sure, so we should call it a day. And thank you very much for attending this. Thank you, sir.